we move on now to Dr. Julian Abel, who you have heard a lot of us mention his work already, but I'm sure he has a lot of new things that he wants to talk about. And you know, one thing, Julian, that sort of struck me in our conversations, you said that compassionate communities is one of the most effective therapeutic tools we have in improving length of life and well-being. I think that's such a strong statement. So welcome, Julian. Julian is the director of Compassionate Communities UK. And really what they're trying to do there is the broader rollout of compassion communities in both primary care and end-of-life care. And then again, there are multiple projects that are happening between the UK and other international programs. So without further ado, palliative care, major blind spots and the new essentials. Welcome, Julian.
Thank you. Can you hear me all right? Yeah, good, jolly good. So look, what a pleasure it is to be here. And how do I follow a presentation like that? You know that Samar is amazing because the work she did on bereavement really changed the way that I think the overall model of bereavement. And then this presentation in particular about showing the benefits of taking a compassionate community approach is groundbreaking and highly significant. I'm going to talk more about that, and let's see what we can come up with in the time that we got. So I'm really happy to be here and great to have such an international audience. So the palliative care blind spots. Oh, hang on, I've got to make sure I've just pressed the right button before I start the sharing, because otherwise I've got some videos to play. Yep, we're safe. That's jolly good. Right, there are 4 major palliative care blind spots. I don't even know if blind spots are the right word, because somehow these things are even bigger than palliative care itself. But let's just go through them and see what we come up with. So palliative care, there's a few things that are problematic with the kind of whole basis of which palliative care works. One is it's deficit focused. That when you look at how palliative care in general looks at helping and supporting people, it's done through needs assessment and control of symptoms. But if we think about what really makes our life worth living, once you put the needs assessment and the symptoms to one side, what is it that matters most to us? Then it's around the people we know and love in the places we know and love. Social ecology. And when you look for the literature about what living well means at end of life, and I find this so amazing, that the literature on living well for both the person with the illness and with the people who surround and support them, it's not just scarce. The literature is absent. In other words, we in palliative care have made the assumption that living well is control of symptoms and needs assessments, which is crazy because living well outside of palliative care is all about relationships. When you look at the research on it, humans are social animals. We evolved as social beings. Survival of the fittest is some kind of nightmare scenario invented by Herbert Spencer, not by Charles Darwin. Actually, Charles Darwin's last book was The Expression of Emotions in Man and Animals. He was intensely interested in relationships. And there are some outstanding pieces of work in the world of medicine. They just kind of point towards this stuff, really. And Samara's already shown you this slide, but this slide is a meta-analysis of of over 348,000 people, looking at the impact of reducing your risk of dying from a variety of different interventions. And this is an extremely carefully conducted study. And mortality was the length of time that was seen for around length of life was 7.5 years. It's a very short period of time in terms of mortality. But even in that short time frame, what you can see is social relationships are more effective at keeping us alive, at reducing our risk of dying, than giving up smoking, drinking, diet, exercise, and anything else you care to mention. And I highlighted down the bottom the drug treatment of high blood pressure because the impact of social relationships outweighs the impact of treatment for high blood pressure by a factor of 4. And I also I have really big doubts about ascribing the increase in reducing your risk of dying with the drug treatment of hypertension being solely due to medication. And actually, why is this so important? Why is it that social relationships have such a profound impact on us? And actually, it's because it's part of our evolutionary heritage. That survival of the kindest is a much better description, particularly for human evolution, than survival of the fittest. We are social beings. If we became isolated when we were living hunter-gatherer lifestyles, our life was at risk. It was a matter of an emergency. And if you think about food security, our ability to bring up children, our ability to, if we're injured, to be helped and supported, it's all about how we cooperate with our community. And when you look for the evidence of this in our biology, it is everywhere. In fact, it's everywhere throughout the animal kingdom. What we're looking at is 600 million years of evolution and 2 million years of human evolution. And you find the evidence in our genomics, in our biochemistry, physiology, behavior, absolutely everywhere. And I really strongly recommend looking at the work of George Slavich and Steve Cole, who have tracked this down to a biochemical and genomic level. It is groundbreaking stuff. But the reality is that compassion is part of our evolutionary heritage, and everyone has the potential for compassion. Everyone. It's there if we choose to use it. And when we do use it, the impact is absolutely dramatic. This is Robert Waldinger. Samar's already given us some quotes, but Robert Waldinger is a 4-study lead of the Harvard and GLUEC studies of adult development. It's been going on since 1938. They've been interviewing initially men since then on an annual basis. And Robert Waldinger is a 4-study lead because it's been going on so long, they had to renew them. Let's hear what he has to say.
Time. So what have we learned? What are the lessons that come from the tens of thousands of pages of information that we've generated on these lives? Well, the lessons aren't about wealth or fame or working harder and harder. The clearest message that we get from this 75-year study is this: good relationships keep us happier and healthier, period. We've learned 3 big lessons about relationships. The first is that social connections are really good for us and that loneliness kills. It turns out that people who are more socially connected to family, to friends, to community are happier, they're physically healthier, and they live longer than people who are less well connected. And the experience of loneliness turns out to be toxic. People who are more isolated than they want to be from others find that they are less happy, Their health declines earlier in midlife, their brain functioning declines sooner, and they live shorter lives than people who are not lonely. And the sad fact is that at any given time, more than 1 in 5 Americans will report that they're lonely. And we know that you can be lonely in a crowd and you can be lonely in a marriage. So the second big lesson that we learned is that it's not just the number of friends you have, and it's not whether or not you're in a committed relationship, but it's the quality of your close relationships that matters. It turns out that living in the midst of conflict is really bad for our health. High conflict marriages, for example, without much affection, turn out to be very bad for our health, perhaps worse than getting divorced. And living in the midst of good, warm relationships is protective. Time.
So the next issue is the issue of equity. And when we think about palliative care, you know, the historical development of palliative care, that the bulk of it has been providing care for people with cancer. So when you ask palliative care services about the breakdown of the diagnoses of the people they see, it's mostly cancer, anything from 80 to 95%. But cancer only accounts for 25% of deaths. And what happens to the other 75%? And what happens even in that 25% of those people who don't have any indirect or direct contact with palliative care services? One of the things I've started to do is to ask healthcare providers, who do you leave out at end of life? And it becomes quite shocking. And in particular, Alan mentioned at the beginning, the social morbidities that come around end of life, and of depression, anxiety, school refusal, job losses, suicide, alcoholism, drug abuse, sexual acting out. The social morbidities happen irrespective of diagnosis, and the physical morbidities and mortalities that come from there are really significant. And it is crazy to think about end of life by diagnosis or age. And sometimes you hear this phrase, hard to reach. I hate this phrase, hard to reach. What on earth does that mean? Does that mean that those people who are being referred to are deliberately hiding themselves from services? And that becomes terrible when you think about it in a context of racism, of inequity of access to palliative care for diverse communities. Actually, the so-called hard to reach are the majority of people who die and the people around them. We've heard about the, Samar's already told us about her groundbreaking research about looking at where people get support from. I have an issue with this diagram, as Samar does, and the issue is one around power relationships, because it seems like the pinnacle of support for bereavement is the one-to-one specialist report. But amazingly, you saw in Samar's research that the most effective form of support is around tier 1. And a better way of thinking about it is to think that everyone, 100% of people, need support of family and friends and connectedness, because the social connectedness is the most powerful biological thing we can do. And so that when we're thinking about how bereavement services, at the moment, a small minority of people see the professional support of bereavement services, but actually everyone should connect through family, friends, and neighbors. And this becomes more like a sieve. But it's not just that people work their way down, because even then the professional services need to connect with the 100% of community. And the final blind spot is around research. And when you look at the definitions of what palliative care is from a variety of different sources, it's a very all-encompassing definition. And then you take a look at what are the papers, what's the research evidence in us being able to meet those definitions. And what you see is a really narrow paradigm of what research is looking at. And when you think about the most meaningful things around death, dying, loss, and caregiving is love, laughter, and friendship. And how much do research methods look at that? And not just for the person with the illness, but for the whole of the supportive network. And this narrow view completely is embedded in the whole of research, bound up in grants, in ethics committees, in peer review, in publication bias. We need a new research. One of the things that I love about the research that Samar's done is you can see the evidence for some of these new types of research, which is looking at social connectedness. And this business about social connectedness, showing an intervention which improves social connectedness, gets absolutely to the heart of it, because that's the thing that has the most powerful biological effect. Let's now have a think about how palliative care can be different. And Alan and I edited the Oxford Textbook of Public Health Palliative Care. Some fantastic, 44 different authors from around the world, encapsulating this whole approach in one place in the first time. And we just did an introduction to basically explain it. Hello and welcome to the introduction to the Oxford Textbook of Public Health Palliative Care. My name's Dr. Julian Abel. I am one of the editors, along with my colleague and friend, Alan.
Hi, I'm Alan Kelleher, friend and colleague of Julian Abel. I'm the co-editor with Julian on the Oxford Textbook of Public Health Palliative Care. And together, we're going to introduce the book as a whole. And the first thing I should say about public health palliative care is often people think of public health in the way that universities teach and research public health, and that is in terms of the surveillance sciences. People often talk about public health in terms of epidemiology or health services research or the bench sciences, or they think historically about public health, such as sewerage, clean water, infectious disease, sexually transmissible diseases, those kinds of things. But in this particular case, and in our book, and within the field of palliative care, when we speak about public health palliative care, we're talking about the health promotion traditions, the traditions that emphasize the practice models, such as community development or social ecology or health policy or services redesign, or public education, health and end-of-life literacy. They're the kinds of things that we emphasize. And conceptually, health promotion is also about a balance between health and well-being and illness and disease. And traditionally, palliative care has tended to emphasize the illness and disease side. And that's why the emphasis has been firmly and wholly largely on symptom management or symptom science. And of course, health promoting palliative care or public health palliative care does have an emphasis on that as well. We're interested in the prevention and harm reduction and early intervention around the experiences of illness and disease, and some of the social morbidities such as loneliness or job loss or school refusal, and stigma and social rejection. So we're interested in that too, but we're also interested in health and well-being, which is the more counterintuitive aspect of palliative care. People often forget that there are positive things that are associated with living with a life-limiting illness, or living with caregiving, or living with grief and bereavement. There's not just fear, but there's courage. There's not just loneliness, but there is love and growing intimacy. There is reminiscence and there is meaning making. And there's a whole group of positive things that are associated with the social nature, not just of dying, but of caregiving and grief and loss. And so the promotion of those health and well-being aspects and experiences at the end of life go together to help with the prevention and harm reduction of the social comorbidities associated with those experiences. This book is about the promotion of those things together, the promotion of health and well-being, the development of the practice models that would help us do that, and the practice models that would help us with prevention, harm reduction and early intervention in this new approach, the public health palliative care approach.
And we also wanted to emphasize that death, dying, loss and caregiving is not restricted by disease or age. And likewise, not by gender, by diversity. It is a question of social justice that we need to find a population-based model that will help everyone. And also that it's not just about the person who has got the illness, it's also about the caring network of people who are affected by that. And that caring network extends into community, it extends into our places of work, our places of worship, our educational institutions, it extends everywhere. Death, dying, loss and caregiving is not just a professional issue, it's a social issue that involves all of us. We invited, that'll do for that. So John's already shown you this slide, the new essentials. And what we're going to do is we're just going to whiz through in the remaining time we got about how these things can work together. And that we have defined this in the context of these 4 cogs of specialist care, which we know about, generalist care, which is primarily about GP surgeries, etc., etc. But the stuff that makes the biggest difference in life is in our neighborhoods, in our communities, and everyone in all of these areas has a civic life, and the civic life is defined in the 13 different domains in the Compassionate City Charter. And death, dying, loss and caregiving is everyone's responsibility. And it's not just about meeting needs and controlling symptoms. It is about those positive qualities that happen in life of love and laughter and friendship and support and courage and intimacy, etc., etc. And that in particular, that when we formulated the 4 cogs diagram, it is about their interconnectedness. It's about all of this working together. And if you like, the way that I think about this is thinking that the chain is community development. Okay, I'm not going to dwell on this slide. And if you think about the things that each of those 4 cogs can do differently, about how can these professional services integrate with community, is actually, you can think about palliative care services being set up to meet the support of the professionals. And we're using this, since the pandemic, we're using these methods of contact every day. And why not have a team that is available 24 hours a day, being able to talk to other professionals to support them? It is easy to do. And then you can think about how can you set your services up so that if you have that kind of contact, you can go out and give advice and do visits if necessary. And what is this craziness of specialist beds being primarily around for people with cancer? This is some kind of artificial categorization that we've made that doesn't relate to the lived experience of death, dying, loss and caregiving. And we can think about what is the stuff that community can do that that doesn't have to be done by professionals. In other words, there's a whole shift in the development of where your professional investment goes, and that specialist palliative care can make sure that they're doing the things that actually enable death literacy in the community, and really practical things. And, you know, the Compassionate Community Connector program is a great example of how you enable network development. And that's come from professional services. And that's exactly as it should be. And why do we not train every single carer in manual handling? What kind of insanity is that? I hear sometimes people talk about, oh, we might be sued if we train them and it goes wrong. So you have to ask the question, is it better to avoid the risk of suing and allow people to move the people they know and love who are closest to them in a way that puts both the person doing the moving at risk and the person being moved? Or is it better to find ways of educating everyone that will give them a better idea on how to do it? And then the other thing that the specialist palliative care teams can do is participation in the implementation of the Compassionate City Charter, which is a geographical approach to improving death literacy, about making death, dying, loss, and caregiving everyone's business. What can generalists do? Well, proactive identification of people in need of support. And it's not, you know, there is no artificial dividing line between people who are dying and people who've got chronic illness. It's a continuum. And that you can have what matters most conversations. Palliative care is obsessed with advanced care planning about where people die. But actually, people want to know, how can they live well? So why not have a what matters most conversation? This goes back to making sure that you focus on the things that are most meaningful in life. And then linkage and coordination with community resource and systemic after death audits. These only take a few minutes. Anyone who died, you should be having a conversation in primary care about, did the things happen that need to happen? And are those people who are left bereaved, are they connected into their community? And development of community resource in supporting people who are bereaved is key. And community development workers need to be seen as part of the clinical team. What matters most, I'm not going to dwell on that too much. Compassionate Communities has got two big chunks. One bit is about the building those resilient networks of support. And you've already heard from Samara about how effective that can be, with the evidence base to show how effective that is. It's fantastic work. And then there is the building of neighborhood capacity and making sure that neighborhood capacity is present. And then there is the building of the integration of the trusting relationships with health and social care teams. And again, what you see with this is that the community development worker sits both in the community and also in the professional space. And then there's a Compassionate City Charter, which I'm not going to dwell on, but is a really important part of this whole picture. And why should we use Compassionate Communities approach? Because it massively increases the range of stuff we can do. And it changes the nature of the clinical consultation to think about helping people, not just the person with the illness, but those surrounding them, how to live well. Network enhancement, I don't think I'm not going to dwell on this, and time's getting short, but I love this quote from Bessel van der Kolk. And he wrote a book called The Body Keeps a Score, and it's a kind of exploration of his life story, where he worked in the field of trauma. And this book is so beautifully written, but it's got so much in there that is so helpful. And I love this quote from this book. Social support is not the same as merely being in the presence of others. The critical issue is reciprocity, being truly heard and seen by the people around us, feeling that we are held in someone's mind and heart. And I would add to that about feeling that we hold others in our own mind and heart. For our physiology to calm down, heal, and grow, we need a visceral feeling of safety. No doctor can write a prescription for friendship and love. These are complex and hard-earned capacities. That's such a beautiful quote. There's more stuff about how can people help? You know, there's practical support, but most important is love, laughter, and friendship. And when you see those slides which says everyone appreciated the social support, this isn't just a nice to have. This is a deep and profound connection at a biological level that gives life's meaning. And when you think about the practical support, is that in a way that practical support, of course, people are grateful for it, but it is the way in which that practical support is given. That sense of giving without sense of return. That sense of people holding you in their hearts and minds. And that's the thing that makes the biggest difference. Compassionate communities as a definition is so great. Compassionate communities that recognize that all natural cycles of sickness and health, birth and death, love and loss occurred every day within the orbits of institutions and regular activities. A compassionate city is a community that recognizes that care for one another at times of crisis and loss is not simply a task solely for health and social services, but is everyone's responsibility. And one of the beauties of this definition that Alan put together is he doesn't just talk about the deficit-based things. He talks about the meaning and value, and that the place for intervention is in our workplaces. It's in our places of education, our places of worship, in our civic spaces, etc., etc. Okay, so I think that's enough from me. I think I'm more or less on time, and we'll call that a day.